Ever seen a dark spot in someone's mouth and wondered what it could be? It might be totally harmless, or it could be a sign of something serious. Today, we're diving deep into the world of oral pigmented lesions. We'll break down how to tell the difference between a simple spot and a potential problem, giving you the clinical framework to approach these lesions with confidence. Stick around, because by the end of this video, you'll know exactly what questions to ask when you see one. First up, let's talk about the most common pigmented lesion you'll encounter, the oral melanotic macule. Think of it as a freckle inside the mouth. It's a flat, well-defined brown or black spot, usually small, maybe just a few millimeters in diameter. You'll often find them on the lips, the gums, or the roof of the mouth. The key thing about these macules is that they are stable. They don't grow, change color, or become raised. If you see a lesion like this and the patient's history confirms it has been there for years without any change, you can generally just monitor it. However, if the spot is new, has an irregular border, multiple colors, or is larger than 7 millimeters, that's your cue to perform a biopsy. We need to rule out anything more sinister. It's always better to be safe and get a definitive diagnosis from a pathologist. Remember, a stable history is reassuring, but any change is a red flag. Next, we have the melanocytic nevus, which is essentially a mole inside the mouth. Just like moles on your skin, these are benign collections of nevus cells. While they can appear anywhere, the most common spot for an intraoral nevus is the hard palate, followed by the gums and lips. Clinically, they can be flat or slightly raised, usually have a uniform color brown, blue, or black and smooth, regular borders. The big question with a nevus is, should we remove it? The logic is straightforward. Unlike skin moles that we can easily monitor for changes, an intraoral nevus is in a location that's hard to see and track. Plus, and this is a critical point, some types of oral melanoma can look very similar to a benign nevus in their early stages. Therefore, the standard of care for most intraoral nevi is complete excisional biopsy. This serves two purposes. It provides a definitive diagnosis, confirming it's benign, and it's also curative. Once it's out, you've eliminated any future risk of it changing or being misdiagnosed. Now, let's discuss the one we absolutely cannot miss, oral malignant melanoma. This is a rare but incredibly aggressive cancer. It accounts for less than 1% of all oral malignancies, but its prognosis is often poor, mainly because it's usually diagnosed late. Early detection is everything. Oral melanomas have a strong preference for the hard palate and the maxillary gingiva, the upper gums. So, any pigmented lesion in these high-risk zones should immediately raise your suspicion. When you evaluate a lesion, think of the ABCDE rule, adapted for the mouth. For asymmetry, one half doesn't match the other. B for border, the edges are irregular, scalloped, or poorly defined. C for color, there's variation in color, with shades of black, brown, red, blue, or even white. D for diameter, typically larger than 6 millimeters, though they can start smaller. And E for evolving, any change in size, shape, color, or symptoms like bleeding, ulceration, or pain. If you see a pigmented lesion, especially on the palate or maxillary gingiva, that fits any of these criteria, you must act fast. An urgent biopsy is mandatory. Don't watch and wait. Early diagnosis can be the difference between life and death for your patient. Of course, not every dark spot is made of melanocytes. There are several non-melanocytic and reactive conditions we need to consider. One of the most common is the amalgam tattoo. This happens when particles from a silver dental filling get embedded into the soft tissues during a procedure. Clinically, it looks like a flat, blue, gray, or black patch, typically on the gums or the mucosa near a restored tooth. The key diagnostic clue here is radiography. If you take a periapical or by 2ing X-ray of the area, you'll often see tiny, radio-opaque metal fragments. This finding confirms the diagnosis, and no further treatment is needed. Another common one is smoker's melanosis. This is a diffuse, light brown pigmentation often seen on the anterior mandibular gingiva, the lower front gums in heavy smokers. The pigment is a direct response to the toxins in tobacco smoke. The good news is that it's benign and often fades if the person quits smoking. Finally, we have physiologic pigmentation. This is completely normal, symmetric, and often extensive browning of the oral tissues, most common in individuals with darker skin tones. It's just a natural variation, not a disease. The key is to recognize its diffuse and bilateral pattern and confirm that it has been present long-term without change. So, how do we put this all together in a busy clinical setting? It all boils down to asking 3 key questions when you see any oral pigmented lesion. First, can I explain this lesion with a simple, benign diagnosis? Look for clues. Is it next to a big silver filling? It's probably an amalgam tattoo. Get an X-ray to confirm. Is the patient a heavy smoker with diffuse pigmentation on their lower gums? It's likely smoker's melanosis. Does the patient have a darker complexion with symmetric pigmentation? It's probably physiologic. If you can confidently answer yes, you can often just monitor or manage conservatively. If you can't explain it easily, move to the second question. Is the lesion in a high-risk location? The 2 hot spots for oral melanoma are the hard palate and the maxillary gingiva. Any unexplained pigmented lesion in these areas should be considered high risk until proven otherwise. This location factor significantly increases your index of suspicion, regardless of how innocent the lesion might look at first glance. A spot on the palate is simply not the same as a spot on the cheek. This brings us to our third and final question, which applies if the lesion is in a high-risk zone or if it has any suspicious features. The question is, are there any clinical signs of malignancy? Now is the time to apply the ABCDE rule. Is it asymmetric? Does it have irregular borders? Is there color variation? Is it large? And most importantly, is it evolving or changing? Has the patient noticed it growing, bleeding, or becoming painful? A yes to any of these is a major red flag. At this point, the decision is clear. Biopsy. Don't hesitate. For any lesion that is unexplained in a high-risk location or shows suspicious features, a biopsy is the definitive and necessary next step. By following this simple 3-question framework, you can navigate the diagnostic pathway for oral pigmented lesions systematically and ensure you never miss a diagnosis that truly matters. So there you have it, a clinical roadmap for approaching those dark spots in the mouth. We've covered the common and benign melanotic macule, the must biopsy intraoral nevus, the aggressive oral melanoma, and the various mimics like amalgam tattoos and physiologic pigmentation. Remember the 3 key questions. Can you explain it? Is it in a high-risk location? And does it show any suspicious features? This structured approach will help you make the right call for your patients every time. Thanks for watching. If you found this guide helpful, please give this video a thumbs up and don't forget to subscribe for more practical clinical content. See you in the next one.